Good afternoon, Chair. Your meeting is now live.
Lovely, thank you very much. So good afternoon and welcome to the Governing Board meeting. I'm Dr. Elizabeth Fellows and I'm chairing the meeting today. We're meeting virtually in response to the limitations placed on governance by COVID-19 pandemic. Members of the public have been invited to view this meeting via a link available from the CCG website. Papers for the meeting are also available on our website. Today's meeting is being recorded so that in the event of failure of technology it can continue and then will be uploaded onto the CCG website as soon as possible. So we've all had the papers. Bookmarks have been added to the pack of papers in order to identify agenda items, hopefully to make it easy to follow. And so board members, you're asked to keep your microphones on mute and to only turn these on when you get to speak. Only use the chat function to indicate you wish to speak and don't use it for questions, please, because that, as it's a meeting in public, the chat function's not visible. So can we go round and everyone introduce themselves with your full name and title? So Helen. Helen, you're on mute.
Sorry, apologies. Thank you, Elizabeth. Helen Atkinson, Director of Public Health for Portsmouth.
Thank you, Karen.
Hello, Elizabeth. Karen Atkinson, Governing Board Nurse for Portsmouth CCG.
Linda.
Hi, I'm Linda Colley, GP, Chief Clinical Officer and Clinical Leader for Portsmouth CCG.
Margaret.
Margaret Geary, lay member in Portsmouth CCG.
Lovely. We're still missing Alison Carston.
My name is Carsten Schaft. I'm a GP in South Sea and I'm one of the clinical executives on Portsmouth CCG.
Thank you. Graham.
Hello, my name's Graham Love and I'm one of the lay members on the CCG.
And Nick.
I'm Nick Moore, I'm a GP, Clinical Executive on Portsmouth CCG. With permission, Chair, I'll be leaving the meeting at 3 to attend a meeting about the COVID vaccination programme on behalf of the CCG.
Lovely, thank you, Nick, that's fine. Jackie.
Hello, I'm Jackie Powell, lay member.
Thank you. Ines.
Hello, I'm Ines Richards, Chief of Health and Care Portsmouth for both the CCG and Portsmouth City Council.
Thank you. Dave.
Good afternoon, David Scarborough. I'm the CCG Practice Manager Representative.
Andy.
Good afternoon, Andy Sylvester, lay member.
Simon.
Hello, I'm Simon Simonian. I'm a GP and also one of the clinical executives.
Michelle.
Hello, I'm Michelle Spandley. I'm Chief Finance Officer for Portsmouth CCG.
Thank you. Tawinda.
Hello, I'm Tawinda Uppal, Secondary Care Consultant.
And we haven't got David Williams, so we're still short of those two. We also have in attendance Justina, who is our Head of Governance, and she's taking the minutes, and Joanne Williams, who is our Interface Pharmacist, and we will come to her shortly. So, moving swiftly on, the only apologies we had were for Andy, and he's here. So we're hoping the others will turn up. So agenda, we've got the register of interest. Any changes people have? Stunned silence. This must be a first. I understand that, having said that, Justina, you've got some changes that have been made subsequent to the papers being published for people who've left the organisation. Is that correct?
It is, Chair, and they'll be part of the next meeting.
Right. But I think it must be a first that nobody on the board has got any changes to make. So that's interesting. But we have to remember the register of and declarations of interest is a live document, and it should change because people do different things. So it's important that we do keep it updated and moving forwards. So Thank you for that. So, having said that, declarations of interest for this meeting, we do have for item 4, Linda Colley and David Williams have an interest.
For item 7, Elizabeth.
Not 4.
Item 7, not 4. 7.
Sorry, can't read.
I've got a direct. Yeah, it's a direct interest for me.
Interest because this is your job we're talking about, and so the action I think we should take as a board is the same as we took at the extraordinary meeting a few weeks ago, is that you can participate in conversation, but if it comes to a vote, you cannot take a part in that vote. And Andy, can you confirm that that's right as our conflicts of interest guardian?
Yes, that's correct.
Happy for that. Right. So moving swiftly on, minutes of the previous meeting, and we've got the meeting from the 16th of September. Have people got any corrections or comments on this set of minutes? No. People happy to accept those?
Agreed.
Yes, some comment, thank you. And then moving on, we've got the extraordinary governing board meeting for the 21st of October. Any comments or corrections for those? People happy with them?
Agreed.
Right, and then we're on to paper 3C, which on my list says it's page 27. This is summary of actions, which are mostly complete and full answers given. Have people got any questions about those?
No questions.
Michelle, you've got one gap.
Thank you, Elizabeth. No questions. I've just got an update to the bottom one about the out of area placements.
Thank you.
NHS England have responded to us to say that the patient was admitted to London, but they're unable to provide any further information because it might breach confidentiality. So I think on this occasion we have to accept that is one of our patients, and yeah, we've done as much as we can to find out about it. Is that okay?
Yes, that's that, and obviously we're very keen to protect individuals, so it's down to that level. We have to respect that.
Yeah,
okay. So people happy, and does this way of feeding back the actions help? Personally, I find it quite useful, but just checking because there's some really nice full answers here. Lovely. Okay, now we're on to item 4, which is Joanne Williams, and I would like to hand over to you, Jo, to talk us through this paper, please.
Thanks, Elizabeth. So I'm Jo Williams, interface and formulary pharmacist for Portsmouth and South East Hampshire areas, including the hospital. I'm bringing to the board a paper because I'm leading on a proposed merger of 3 prescribing committees. So currently we've got one for the Portsmouth area, one on the Isle of Wight, and one also in Southampton area. And the proposal is to merge across the ICS area to form one Hampshire Isle of Wight prescribing committee. I previously have taken the proposal documents to our clinical advisory group, but they were generally supportive of that. But because they weren't a formal decision-making committee, it was felt it was the best place to come to the governing board. I don't know which other papers were circulated. I certainly saw the impact assessment was circulated to you also. I don't know if you've seen all the consultation papers or if you have any more questions about that. The plan is that the consultation will run until the end of December, and the hope is that we would have support from the CCG for this proposal, and that the merger will be complete in April time, which would correspond to the proposed start date of the new Hampshire Isle of Wight CCG.
Okay, thank you. People, any questions? Comments? Nick, you sit on the area prescribing committee, don't you?
Yeah, I mean, it's been discussed there, and I think that the committee itself, as people have raised different views about it. My only question really for Joanna was about, obviously, if that there is going to be a wider merger, will there be any stuff that comes down to a more local level? Because obviously certain things will happen on a footprint that relates to our acute hospital, and therefore they may not always necessarily be relevant, although lots of stuff does, and lots of stuff, for example, with Solent, where they have sexual health across both cities, obviously does make sense. So what would happen with the stuff that only would sit more locally? I'm not sure if we've quite resolved that yet.
I think it's not necessarily, the expectation is that it will go down to a local level decision for anything where that's relevant. It's whether or not that would be a subgroup, or whether it's just a dotted line between two committees. The expectation is that the new committee won't be a formal decision-making committee anyway, so any decisions would need to be made locally, or just be us making recommendations. So there would need to be a forum for that.
Sorry, so what would the forum for those decisions be? Because that's I think that's what we need to kind of understand, I think, is that we would have a wider ownership, so that we have an overarching strategy and agree stuff at a bigger level. But if the decision has to be made, where would that come?
So the expectation is there will be an ICP, so similar to our current footprint for the area prescribing committee, where anything that is particularly local, say around Portsmouth hospitals, that would feed into that. But as a CCG, we would need to make formal decisions on any recommendations, particularly where there's financial implications.
But we could have a subgroup, smaller committee that kind of mirrors what APC does at the moment to do some of that decision making.
Yeah. I think the expectation, though, is that it'll probably only be stood up if required, rather than being meeting as regularly as we currently are.
And any significant expenditure things will either come to our clinical advisory group, or would they need to come here then?
But that's another question that we have, because if the clinical advisory group doesn't have financial accountability or authority to make those decisions, it probably needs to go to a different place within the CCG. So that's another question that I have, really.
Okay, thank you.
Right, yes, so we'd certainly have to look at that reporting structure and for where those decisions get signed off. Graham, you've got a question, comment?
Yeah, it's only about the geography, Joanne. Am I right in assuming, therefore, that the current Southampton district covers all of north of Hampshire if the merging of these three is covering that entire footprint?
Yes.
Right.
Yeah, so the district prescribing committee covers Basingstoke, Southampton, trying to think, there's another hospital in there as well. It's the Hampshire Hospital footprint, so it's Winchester as well, isn't it? Yeah.
Yeah. Okay. Thank you.
Right, Jackie, I thought I saw your hand up. Did you change your mind?
I did change my mind. Nick covered the question that I was going to ask, so thank you.
Okay, so question is, where do financial decisions get made? And where's that piece of work going to go on to make those decisions? Michelle, do you have a feel on this?
I think we probably need to explore what happens now. Bearing in mind, I can't remember the last time we saw anything around drugs changes. So it's very timely, I would suggest, to refresh everything. I think it makes sense to do it at Hampshire and Isle of Wight, because then you don't get one hospital having one type, one agreement, and others having something different. I'm happy to work with you, Joe, about the governance arrangements that sit within that as well, so that we can have a smoother transition, not only with ourselves, but maybe with the other CCGs and hospitals as well. That makes sense.
Yeah, that's great, thank you. I know obviously at the moment we do feed into the clinical advisory group, but again it was commented that that's probably, although it's a good forum because obviously clinicians are there, it's probably not the right place in terms of the financial accountability. So
yes, Lovely. Happy with that.
Yeah, and I would suggest that clinical advisory group is still the right place for the discussions with clinicians, but it's getting that robustness around the finances that we need to be absolutely clear on. So don't stop what you are doing, but do.
Yeah.
We've just got to get that.
Joe, talk to me about who's most appropriate to help you through that. Given that Nikki's just about to leave us on maternity, you probably need some help.
I'm so sorry. Yeah, I'm also going on maternity on Tuesday, but I will get in contact with you. If it's not me, I'll get Simon to pick it up with you. Okay.
Lovely. Thank you very much. So we are being asked to formally support the proposal and consider the reporting structure, which I think we've done now. It's proposed that the prescribing committee holds no financial accountability, and the decision will be needed to be made on that. So are people happy with that proposal?
Agreed.
Yes.
And those are the considerations. So do we feel like we've covered that off sufficiently? Are you happy with that, Joe?
Yes, thank you. And I'll leave the meeting now. Thank you.
Thank you. And best wishes for your maternity leave. We hope for a good outcome.
Thank you. Bye.
Bye-bye.
Bye-bye.
Right. Linda, item 5, your Chief Officer report.
Yes, thank you, Chair. I was proposing, making the assumption that everyone's read the report, and I was proposing just to focus on 2 areas that I need board's approval on from today. So I was going to start with the SHIP Priority Committee and evidence-based interventions. As you are aware, we discuss on a SHIP-wide basis policies, both national and local ones, to make sure they're aligned with current evidence and best practice, which then come back to our clinical advisory group where we look at the clinical implications and discuss, and then obviously comes here for approval. So there are 4 policies I'm bringing in today, which were produced following the July meeting of SHIP, and that have been through clinical advisory group and have recommended them up to the board. So this is policy 14, subacromial decompression of the shoulder. Policy 29, surgical management of pelvic organ prolapse. Policy 63, treatments for erectile dysfunction and penile rehabilitation following radical prostatectomy. And policy 65, low intensity pulsed ultrasound in delayed and non-union fractures, version 2. There's a little explanation next to each one there, and CAG have approved these. Do the board have any questions, or are they happy to approve CAG's recommendation?
We
got a thumbs up from Jackie.
Yeah. We get some nods.
Yeah. We will find a steady flow of these coming through in this manner. If you do ever have any extra questions about them, please do highlight it to us, and we can bring more information if needed. The second one I wanted to focus on in my report was the eating disorders. This is for the Portsmouth City footprint, and this is part of the Children and Young People's Mental Health Local Transformation Plan, which identified eating disorders as amber. And as you know, eating disorders has got a national ask at the moment. It does need some focus, and several actions during the plan related to tracking, monitoring, have given great understanding of what the challenges are, and it's resulting in the fact that it's clear that we need some additional investment. Looking at how we offer eating disorder services in the city, it's part of the extended CAMS team, which is struggling with capacity to meet what is a very complex area and a lot of demand. So what we are very good at is doing the urgent high-risk patients very quickly, but this does have a negative impact on the wider CAMS waiting times and on the more routine referrals. So work has been done, and it's reviewed what is required, and there is an additional ask, and this is a recurrent ask. So the current service currently has 108,788 as recurrent funding, but it needs to increase by 208,947 to make the total recurrent funding. If I've got this wrong, Alison, please do highlight, but the total recurrent funding would be 317,735, and it's broken down there how we've got to that point in terms of costs. Margaret's got a hand up. I don't know if that's about this or.
Yes, it is about that. It's,
yeah.
Just to welcome the fact that I think some attention has been given to the capacity issues, because certainly inequality to CAMS this stood out as an area where the demand was rising and the capacity was squeezed. One of the only comment I had to make on it was really that one of the other issues that came out was that the timing of the offer of the service to young people, and that seemed to be out of sync with when young people were available. So the best times were between after school, basically, until about 8 o'clock. And I'm not sure that that will be factored into any revision of or review of the service. Hopefully that it will be, because at the point when we were visiting, our services ended usually 5-6 time.
Okay. Interesting point. Yeah, I see. Alison, do you know if that has been taken into account?
I think this is kept under review, and the service has a sort of dialogue with service users and schools. And I'm not sure what the latest information from what young people are looking for, what families are looking for, but I guess there is an acceptance that sometimes children do need to go to morning or afternoon appointments during school time, and also that the after school time can be difficult for some families with other children and doing evening domestic stuff, etc. So I haven't heard that there's a significant issue in terms of the appointments being issued at the wrong time. It's not come up been escalated to me at the moment.
It was just the lead in CAMS who was fairly isolated at the time, dealing with these demands, and she was the one that was saying that really the service needed to be beyond 3 for that particular, for eating disorders in particular.
Oh, okay. And was that recent, Margaret? Sorry.
It was about 8 months, 6 months ago.
Okay.
8 months ago.
I will look into that with the team, with the commissioning team, and also with Sonia King at Solent to see if that's still an issue and whether we need to resolve it. It may have been resolved. They may have actually extended the appointment time, so I just need to check that out.
I've got a question, because I know at times we've really struggled with workforce for CAMS. So even if we supply this funding, is there a workforce out there to be employed to expand this service?
My understanding is yes. I don't think we're anticipating a difficulty filling these posts.
Good. That's great news. Thank you.
So we do need the board to approve the additional funding, and as you say, is going to be recurrent. So the additional funding we're approving is 208947. Is the board happy with that?
Yeah.
Brilliant.
Yep.
Lovely. As I say, Elizabeth, I wasn't necessarily going to go through any other items unless there was any questions that people specifically wanted to pick out from the report.
Has anyone got any other comments or questions? Graham.
It was only a comment that I note the NHS requirement around the patient safety specialist, and certainly from a national presentation I went to a year ago, that feels like a really sort of positive step in the right direction.
Yep.
Lovely, thank you. Okay, so are we all happy to accept Linda's report otherwise? Everyone sorted for that?
Yep.
Thank you.
Thank you.
So we now move to, I've got to go back to the agenda. I'm in the wrong place. Sorry about this. IT is a wonderful thing. It's Helen's update.
Thank you, Elizabeth. I will share some slides.
Thank you.
And hopefully you can now all see the slides. Great. So I'll just go through a few slides just to give an update on the current situation in terms of coronavirus in Portsmouth. So I'll cover the infections, including the case rates per 100,000, weekly rates, age-specific rates, and then deaths. So if we look at the first slide, this shows that we have 622 new infections in Portsmouth recorded in the past week from all testing, which now takes us to 3,749 total cases since the beginning of the pandemic. Initially, most of the positive cases were in this particular wave of 2 were in younger adults, but who were not becoming seriously ill. But now we are seeing an increase in the other age groups, and that is also starting to obviously impact on NHS pressures. You'll note from this particular epidemiological curve that much higher on the right hand side in the current second wave is because we weren't testing everybody in the first wave. So if we just take that into so you can see across in terms of our comparators across Hampshire and the Isle of Wight, these are the spark lines. You'll see that across all of the different local authority areas that there is an increase in cases now as we move up in the second wave. And then when we look a bit wider on our comparators, on the left hand side you have the weekly rate of COVID-19 cases per 100,000 within the whole of England, and you'll still see that the higher incidence areas are in the north, the Midlands, the northeast, and northwest, but there are now beginning to be higher rates also in the southeast, south and eastern region. And on the right hand side you've got a table there with all the comparators. We're currently at a rate of 289.4 per 100,000, and you see that we are the highest in the Hampshire and Isle of Wight patch, and also higher than the southeast average, and also now higher than the England average, with only a couple of areas. Well, we're the fourth actually in the southeast at the moment, with Slough, Swale and Dartford ahead of us. But we'd start showing some age-specific rates for Portsmouth, and you'll see from this graph that chart that this is cases in the last 7 days broken down by age group. You'll now see that the rates are now highest among the 45 to 59-year-olds, followed by 30 to 44-year-olds, whereas a few weeks ago, we were seeing the highest rate in the 15 to 29-year-olds, which has now substantially come down. What's also of concern is in the red line, which is the over 60s, is increasing, and it's most likely that this age group are the ones who are most likely to end up with more serious illness and hospital admission. But across all age groups, apart from that, the 0 to 14 and the 15 to 29-year-olds are now going up. And then we just also looked at specifically in children. So case rates in children are generally lower than the rest of the population, but the rates are higher and rising more quickly in our older children and young people, so secondary school age group. If we then look at our local hospital, Portsmouth Hospital, we are seeing that we are increasing in terms of hospital admissions, and it's increased by 50% within the last week. We're starting to see significant pressures in the NHS and particularly in the acute sector. And if we quickly just look at deaths, there have been 9 COVID deaths recorded at the QA hospital since the end of October. It's important to note, though, that we did have a peak in COVID-19 related deaths up until the 11th of April, and you'll see that that is much, much lower now, although beginning to increase. And then if we look at what we would call our excess deaths, the total number of deaths each week in Portsmouth was higher than in the average week for 5 weeks only, as I mentioned just before, in the March to early May period. And then since then, week ending the 15th of May, deaths have been below what was seen in previous years. And that still continues, although we are starting to see a slight increase in deaths over the last 4 weeks there, and as you look on the right hand side. But we are still within our normal excess deaths range this time of year compared to previous years. And that's it from the COVID update.
Thank you very much, Helen. That's really useful, seeing those figures so clearly set out again. Questions, comments, Jackie?
Hi, Helen. I wondered if you had any idea as to why our rates are increasing so much more than, say, our local area, or in fact the England average. And my second question, if you don't mind, is are we finding that staff, particularly at PHU, are being affected in, you know, the number of staff that are available and this sort of thing, and are they getting rapid tests and results?
Thank you, Jackie. As you know, until September, we were one of the lowest infection rates in terms of the southeast in Portsmouth, which was actually fairly unusual for a city area that is quite built up. So compared to other city areas in the North Midlands and North East and North West. However, we started to see, along with many other city areas where there were universities, so a higher population of young adults, an increase in September. I don't want to say it's all, because it's not all related to the university, because we also, like the north of England, those cities with younger populations, with young adults returning from holidays in Europe, started to see an increase. And we can now see from that data, of course, that our young adults infection rate is coming down significantly, but our other populations. So in line with other areas in the country, particularly city areas, we have seen an increase in our young adults in the initial stages. This happened also in the north of England. And then that spreading in terms of community spread into other age bands, and starting to see an increase in particularly our older adults and our more vulnerable populations. And that is, we've been behind in terms of timeline of other cities in the northeast and northwest of England, but that is exactly the same pattern that those areas showed, particularly as we moved into wave 2. And we are starting to see, and I know we might be the highest in terms of the Hampshire and Isle of Wight patch, but we're not that much further ahead than Southampton, who have also seen a significant increase, as well as other city areas in the southeast of England. And then your second question, we are, as I've said, seeing an increase in the impact, therefore, on the acute sector, and particularly in Portsmouth. And that there's been a number of outbreak situations, what we call nosocomial outbreak situations, which are not necessarily just admissions to hospital, but where people have converted into a positive coronavirus within the hospital that have been followed up. And staff will be, as I understand it, there's a national and a regional rollout of lateral flow testing for all patient-facing staff starting next week. So there will be weekly testing, or what we call weekly testing of asymptomatic staff, that should be starting in Portsmouth hospitals and across the region from next week.
So do you think they have been impacted operationally in the way, in their ability, actually perhaps the whole system's ability to respond? And I didn't quite pick up why the 45 to 15-year-olds are so exponentially greater than the younger ones.
So I think it's fair to say that there is impact now, as expected, in the NHS across, and it's not just in Portsmouth, I would say across the whole of the sector. And in fact, I was on the regional meeting, and there are greater pressures currently in the Kent patch than there are across the rest of the region, but there are pressures across. The systems that we work in the NHS across, obviously the Hampshire and Isle of Wight ICS, Integrated Care System, and there are arrangements both within the system and across the region to ensure that there is mutual aid and the ability to move patients around the system when it's needed. So, for instance, if one hospital is at capacity for intensive care beds, there's the ability to then refer patients elsewhere. That has not had to happen yet in this patch. So there is capacity, although the whole system is under pressure. And that's not just the acute system. Obviously, the whole of the NHS is under pressure, as we would expect at this point in the second wave, and that will continue up through now into the winter months, which we are heading into now, through wave 2. Then the second question, why in that age group? In terms, well, what we have seen since the beginning, and that was in wave 1 of the pandemic, is that younger children, particularly primary and age, have been less affected by coronavirus, both in terms of their illness and getting COVID, as well as spreading. So what we are, which is not particularly normal in what we wouldn't normally see necessarily in winter infections. So as you know, children often do get and spread winter viruses, but that has not been the same with coronavirus. And what we're seeing is that it is in the older, as it was with the what we call the young adults, that it is increasing as we are in wave 2. We expect to see the rate of infection, I'm sorry to say this, but we will expect it to continue to rise as it spreads. As we are, I suppose, we go up into the pandemic curve. That is why it's called a pandemic curve, because the numbers will go up to peak, and then they will start to come down. The good news, of course, in all of this, and I know that Nick mentioned earlier that he's going to a COVID vaccine meeting, is that we will have a vaccination programme in early next year. So I think it will be there will be some vaccination for the most vulnerable people, so people in their over 80s and care home residents in late December, but the rollout of the programme will be into early next year's spring. It will take about 8 months. So that's the good news. I think we have to put, we are in wave 2. It's not going to be getting any better in the next few weeks. And obviously, we've just got to look forward to the vaccination programme impacting for next year.
Okay, thank you.
Thank you very much. Has anyone else got any comments or questions? No, lovely. Thank you very much, Helen. And perhaps you can send your slide pack to Justina, and she can circulate to the rest of the board. Thank you. Right. So item 7, and that's page 39 of the board papers, is we're coming back to our Health and Care Portsmouth commissioning operating model. This is following our extraordinary board meeting in October, where we put a suspend on 2 recommendations of approving the amendment to our constitution to move to a managerial AO and the revised composition of the governing board. I was asked to write to NHS England to seek clarification as to why our original proposal was not accepted. I did, and we also, both Linda and I, had conversations with David Radbourne at NHS England, and the summary of those conversations and my letter were as follows. So if I list these out as recognition of the work that's been done. So NHS England are still supportive of our hybrid model of a shared AO, but Portsmouth remaining as a statutory entity. So that's despite the national stated policy of there being usually a single CCG for each ICS. And as part of this, our shared AO role needs to be shared with other CCG commissioners, and also to be the chief officer of the ICS. So it cannot be the local authority chief exec. And with regards to the models that have appeared in recent weeks that had prompted my question in the first place, NHS England were clear that these arrangements in other areas are interim arrangements, and that they have the full support of their ICS partners. It was also made clear to us that there is new legislation likely to be coming down about integrated care system arrangements in Q4, so that's January through to March, or Q1 of the following year, April through to June next year. And that will strengthen the integrated care system arrangements, and other arrangements will need to be reviewed in light of this. NHS England are also supportive of our city integration model and keen to see us to continue with this and succeed with Health and Care Portsmouth moving forwards. So that is the feedback from NHS England as requested by the board in October. And following that, do people have any other questions or comments they would like to make about this decision that we suspended in October? Suitable stunned silence. So can I take this forwards and ask for, do we approve the proposed amendment to the CCG Constitution to move to a managerial AO, a post to be shared with other CCGs in Hampshire and Isle of Wight, who will also be the Chief Executive Officer of the Hampshire and Isle of Wight Integrated Care System? Lots of nods. Thank you. And do we approve the revised composition of the governing board with effect from April 2021? Thank you. So, thank you very much for all of that. We can move forward and we will be looking very soon at the next steps and how we work, and we will be moving forward differently and working closely to sort out those tiers of commissioning so that we can be clear what's done at the city level, what's done with our local neighbours around Portsmouth hospitals, and what's done across Hampshire and Isle of Wight. So thank you very much for that. Moving swiftly on, I would suggest we go to Innes for our plan for Health and Care Portsmouth.
Yes, thank you, Elizabeth. So you'll probably be relieved to know that I won't be talking to every page of this long document. It is a long document, I think quite rightly in this case, because it has begun to capture all the work of Health and Care Portsmouth, crossing children, families, adults and public health. It is the beginning of a process. This is not a document that brings a set of priorities for us to sign off seal at this meeting. There is active engagement with partners on all of these plans. This is a set of plans going on. That engagement is at different stages depending on the topic or the focus and the partners, and so therefore it's quite right that we bring a draft, well I think it's quite right we bring a draft document here, given we want to continue to engage with partners but also families and users and residents as well. The idea here is for the board to have sight of them, to endorse the approach, and for us to get on with the completion of the approach. I understand that all the strategies are on a timeline to have completed by and in place by April next year, which lines up with our operating model discussions as well. We've had an opportunity to discuss a lot of the detail of this in previous sessions as well, which is another reason why I won't go through it as well. But effectively what we have here is a gathering together of the Health and Care Portsmouth blueprint commitments. You'll remember back in 2015 we had a blueprint and a set of commitments. We are just updating and bringing them, refreshing those commitments through discussion with partners. We've had some discussion as board members as well. They're given in Appendix 1. You'll see the suggested additions so far added. I don't think the essence of those commitments have changed fundamentally. I think our intent and our plans still deliver the core of those, and those commitments of course have been built on continual conversation with staff and with users and residents as well, and listening to the feedback we've had on individual services. They also include an overview of the broad work that has been happening under the coordination and leadership of the Children's Trust for Children and Families. Alison has spoken in more detail at previous sessions about the detail in there. I will pause afterwards, Alison, just to give you space to come in if you want to add anything, and yourself, Helen, as well. They are given Appendix 2, and each of those priorities has a strategy plan and a governance framework being built around it as well. Similarly, for public health at Appendix 3, there is early work starting to describe the health and care priorities, many of which you will see cross, importantly, both adults and children and families plans, but there are also some unique and specific public health priorities there as well. That is a work in progress as well, and we are continuing to work with Helen and her team alongside each other on that. In more detail than we've seen previously are the adults plans here as well, because we've only ever presented them in headline form previously, and what is in Appendix 4 are the 6 strategies for adults that are emerging through the conversations and the engagement, and we are also doing the work on the 7 supporting priorities that need necessarily to cut across all of those plans and have a visibility in the city. Safeguarding adults being a prime example, for example, but there are others as well. So, with your permission, Elizabeth, I will not go through each of the appendices. That does unfortunately run the risk of not doing justice to the sheer amount of work that both our teams but our partner teams are doing, of course, but I hopefully board members will acknowledge that as well. What I would like to do is just give Alison and Helen an opportunity to add anything before we move on to discussion and questions. So Alison, have you got anything you want to add?
I think the only thing I'd say is that people are probably aware that next year, 2021, there's a proposal to refresh the health and wellbeing strategy for Portsmouth. And I think what we're doing now provides a good platform for that. But I also think that opportunity next year allows us to dig a bit deeper into some of the causes of health inequalities and try and think broader, even more imaginatively about how we address them. So I'd personally be really looking for more broader. I suppose it's a public health agenda, but one that really engages the whole of our partnership around that to strengthen further our work. Otherwise, and this is because it's a children's trust plan. It's a partnership plan. It has the police very signed up to it and schools. So it isn't just a health and care plan for children, but it does include all our health and care aspirations for children. I'm very happy to answer any questions if anybody has any on the children's aspect.
Thank you, Alison. Completely agree with everything you're saying there. Helen, is there anything you'd like to add?
Well, I think Alison has actually said most of it. I would agree, and I think if anything, the COVID pandemic has shown us even more so why it's important that we focus on the inequalities. We're seeing greater inequalities now than previously, even though this is obviously Portsmouth does see quite a significant with its deprived communities difference in inequalities or a gap. So we really do agree through the health and wellbeing strategy and then through the health and care partnership work is to really focus on our most vulnerable and our most deprived communities, where we would see through really focus on those wider determinants a greater gain. So I think it is the strength of Portsmouth partnerships that we work really well together, and I think we need to really focus there on where we need to be focusing most effort to ensure that we're reducing that gap, which is only going to be heightened when we come out of this pandemic.
Thank you, Helen. Completely agree. If there's one aspiration I would have for the development of this plan is that for me, I don't think it majors on the inequalities work and the inequalities in the city as much as it could do. I think we know them and we work to them. But I think particularly as the NHS side of the commissioning business transforms over the next couple of years, I think it's going to become even more important that our local plans reflect any local inequalities and gaps as well, because that will help us in our discussions, for example, at an ICS level about allocation of resource and prioritisation as well. So it becomes quite an important job for us to do, I think, in Portsmouth. Elizabeth, I was going to hand back to you now as chair, just to chair any questions, discussion. Thank you.
So we've got Dave Scarborough and then David Williams.
Sorry, that was a bit of technical issue trying to come off mute then. The point I just wanted to refer to is a comment stroke question and an invite for further discussion. As you look across the deliverables, there are a number of references to PCNs and the additional role reimbursement schemes, and it shows it to be on track and the funding to be 100% committed, with some experience of utilising the additional role reimbursement scheme. My impression is that these roles won't be 100% taken up by the end of this year. They will be excess funding, and that's partly to do with the impact of the COVID pandemic and the repurposing and redirection of some of the PCN effort, but also because of the intricacies around the scheme itself and what it actually covers for in terms of funding. So in summary, I feel that scheme won't meet its capacity, and I just wondered if there's any sort of further information to add, because perhaps a little bit of a lost opportunity.
Okay. Yeah, I completely take your point, Dave. I suspect what the teams are trying to indicate is that the development and the conversation with PCNs is on track to that, rather than the specific. We are confident we're going to utilise 100% of it. I think we'll continue. I suspect what we'll continue to do, I hope, as a CCG, is work with the PCNs around what we can flex and what we can't flex, because some of this is nationally directed as well. And certainly locally, I think the CCG has been very good at trying to understand what the local issues and challenges are, and then flexing resources as much as we are able to as well. That extends not just to the CCG does as well, but to the ones that the council and public health have done in the past as well. So I would hope we continue that way of working, Dave. There may be others on the call. I was just thinking Michelle, for example, who may have a different opinion around that, but I would hope that be the way we would work, Dave.
Okay, thank you. I would agree with everything that you've said there. But in terms of moving forward, I think what will be important is how that scheme is adapted going into the new financial year, and whether there's any further flex in the system, because certainly the feedback that we're getting in PCNs is the scheme is as is, and there is limited scope for flexibility. But I would note the CCG are doing their best to adapt it accordingly.
I think that's a feature, Dave, of the fact that many of these schemes are nationally prescribed. And as you know, we therefore need to demonstrate that we are adhering to national expectations whilst trying to apply it to a local situation, and it's a balancing act. But I would hope that it would be an equivalent conversation between CCG, PCNs and the individual practices, not imposed.
Okay, thank you.
Michelle.
Oh, right. Come in then.
I would fully endorse us trying to utilise the resources to best effect, and we would need to make sure that we are continuing to have those discussions nationally along the lines of, we think we could utilise the money better if we were able to do it this way, as has been our way in the past. And I think we've demonstrated that we have done that quite successfully in a number of areas. So setting aside this financial year, which is a little bit skewed, isn't it, in terms of the COVID-19 and the response we've had to make to that. But we do need to keep those conversations going so that we are ready for a future that will be beneficial for all. Thank you. Thanks, Elizabeth.
Thank you. So moving on, David Williams.
Thank you. 2 points. I certainly endorse the issue around the attention to issues like inequalities. And actually, Linda and I were on a Vision for Portsmouth dial-in earlier this morning. That is coming to fruition. It's had engagement from over 2,500 Portsmouth residents, and I'm very hopeful that that will give us something to work with. Part of that, I think, the challenge to all of us with that will be, how do our organisations not only engage with those bits that they can clearly recognise are mainstream for what they do and where they operate, but also, I think, in the round as well, how do they contribute to some of the broader issues or the less familiar, less mainstream issues for that particular institution or organisation. And I think that through that, there'll be a number of themes will come through. The inequalities issue certainly will, but also, the issue around the city of sanctuary and so forth. So I think it will be interesting for us to reflect on the visioning work when that comes through, and maybe there will be aspects of this that we might just want to fine tune to demonstrate how in step we are. I'm absolutely confident that this plan is in line, but I just think there might be some bits that we could give greater emphasis to. On a similar issue about emphasis, I think the other thing that I'm quite conscious that we've seen it through the previous agenda item, that there is a little bit of a sort of almost unspoken undercurrent that perhaps Portsmouth is too focused on itself and isn't engaging sufficiently with the wider system. I think it's entirely misplaced, but clearly it's something that we do need to keep reinforcing. And I was just conscious as I look back through it, I'm sure Inez will be able to point to exactly where it says it, but I was just a bit conscious that perhaps for other audiences, we're not reinforcing the message that we are fully and wholly committed to engaging with the ICS and the ICP. Maybe that's something that we could put a mention in about. It's quite ironic, really, given that so much NHS emphasis now is on place, and that is undoubtedly the thing that we are concentrating on in this document. So I wholly endorse the document, but I just think there are a couple of tweaks there that we might be able to build in.
Yeah, thank you very much for that, David. And something I noticed when I was reading through it, there's some sections that are very clear where things are being done, at which tier, whether it's the city, it's the local system, or the wider Hampshire bit. But I think we can be much clearer about that. And certainly, I think moving forwards with our new operating model, that is a piece of work that we will have to be very clear with and share with our partners across the broader footprint. So yes, timely reminder. Right, Jackie, and then we've got Margaret and Linda. Unless Linda, did you want to come in about the vision particularly?
Yeah, so just to back David, I mean, it was a very good meeting, and we've been tasked with kind of moving it forward and keeping momentum. I suggest perhaps a governing board development session once the vision piece is ready to roll, to make sure that we can properly look at it and, as you say, brainstorm on the things that, I mean, there's some that are clearly going to affect us because it's about healthy cities, but the other ones, as David mentioned, culture and things like that may not be directly obvious, but we really do need to try and embrace as an organisation. So I would suggest a development board session for that. And my other comment was really a thank you to the teams, because I think this document is a lot of work. I think it's lovely to see all of it in one place as health and care in its entirety in terms of adults, children and public health. And I mean, it's probably because I go to the meetings of the other layers, but I clearly see how this fits in those layers. And I see a lot of the city stuff as our attempt to do our part for the rest of the system. But, if an audience that's not used to going to those meetings may not. So, yeah, perhaps some fresh eyes on that would be helpful for us, because we're so embedded in the meetings. Sometimes we can't explain it so well, I suppose.
Thank you. So, Jackie?
I completely agree with what's been said, and I would welcome a board development as well. I had a couple of little comments, particularly around the commitments to start with, which I didn't want to add words, but I fear I'm going to. And it was just on item 5, where we're looking at our workforce. I thought it would be nice to say that, we want a workforce that feel supported and know that they're valued, So it's not just about them being committed, it's not just about them, but that we value them and we want them to be well supported so they can deliver for us. So I thought that was an important thing maybe just to add to. I'd still like parents and carers, but I may have lost that one.
I'll do that, Jackie. I didn't realise that until I saw the minutes of the 16th of September meeting, so I'll sort that out.
Okay, and thank you. Can I just quickly just kill the fire?
Okay. Right. While we're waiting for Jackie, oh, she's back.
I'm really sorry because my phone is so shrill and it just will keep going on and on. And one of the things was around the public health. And when we had our Health and Wellbeing Board meeting, it was kind of noted, and it's something for us to keep our eyes on, but with things like substance misuse and alcohol misuse, there is a direct correlation in terms of what you spend on it and what outcomes you receive from it. So creative imaginative thinking is also great, but there's certainly some things we do need to invest in because you get what you pay for. I suppose that's what I'm saying. And my final comment was I hear about positive minds. I'd just like to hear a bit more if there's a moment about how it's managed during COVID. No, I'm shutting up.
Thank you very much. We'll take some of those away as actions, and I'm sure we'll get you some answers. Margaret, and then Alison.
Sorry, I was just going to come back on the inequalities issues that Innes highlighted. We would perhaps need more targeting on. And given that the one thing that COVID has done is made more visible some of those inequalities around poverty, around learning disability, around Black and minority ethnic communities. Yeah. And it feels like there might be an opportunity to raise the profile of health as well. Those are not issues that are going to be sorted by health alone. And in the city, there might be an opportunity to convene something that is wider than health, to actually help us to get better at that targeting of inequalities and think about strategies medium to long term on that.
I would wholly concur with you there. Health is such a tiny bit of life, and I think we have to remember that. And yeah, thank you for that, Margaret. So, Alison.
Well, just in quick response to Margaret's point, the children's section of this, as I'd said before, is a children's trust partnership plan, and it does engage the whole stakeholder landscape, as it were. And tackling inequality has always been an absolutely critical theme for all our children's trust plans. So actually, when you look through this, you see a lot of ways in which it does that. I think I just wanted to flag up. I think the idea of signalling in our plan how we are also committed to working at the ICP and ICS levels is important. But it's also not just recognising that some of the work needs to happen at that level, but also our willingness to share what we're developing in Portsmouth with the wider system. And just as an example of that, Hayden Gins is hosting a call on Friday about the work we've done on neurodiversity in children and the effective response to that, which I think we've got nearly 50 people from across the Hampshire system ringing in to find out about the work that's been done in Portsmouth there, where we have, overtly taken on a trailblazing role for the ICS. So it's not just about what needs to be done at what level, but also a willingness to be part of system-wide improvement in other places.
And that comes back to conversation we've had in the past, isn't it? That we should shine a light on the good work that we have been doing in the city, that we need to let others know about our successes more than we have done in the past. So absolutely.
And I think there is some added benefit from greater coordination and oversight of that at a very strategic level in the city. Maybe others like Southampton who have very similar demographic profiles and are needing to target. But it's not just us, health and local authority, it is police and voluntary sector and a number of others, private sector, who are also struggling to target inequalities, wanting to look at it. And I think that needs to be kind of picked up at some point by someone. And COVID is an opportunity to do that.
Thank you. Helen.
Thank you, Elizabeth. I'm just repeating actually, or building on what Margaret and Alison has said, is so there's some very clear evidence that as important as it is, and obviously the NHS and health are incredibly important in the lives of our residents, but it's only about 25% at the most in terms of impacting on outcomes, on particularly around inequality. So it is the environment, it's employment, it's education, it's all of those things, including also Jessica mentioned substance misuse as important to our lifestyle factors. So these are the things we need to focus on together, obviously, as we've all been saying. And I do think that we've got the right partnership arrangements to do that. And so, it has to be business as well. It has to be whole Portsmouth, which is what I think is so exciting about the way the partners work and stakeholders work in Portsmouth. So I think it's all doable. And I think this is exactly the focus on this plan, as well as the work in the refresh of the Health and Wellbeing Board are opportunities. And we're just going to have a greater task. I think COVID is highlighting, but it's also increasing. So it's just going to be a greater job that we've all got, I'm afraid, now as we move into next year.
Lovely. David, did you want to come back? No.
Oh, sorry, I don't know how I did that, Liz.
Okay. Carsten.
Yes, yes, I like the plan, and it's it's quite excellent, and there's a huge amount of work in there. What I particularly like is in the mental health section. There's a phrase that's used, unfortunately, only there, and it says no wrong front door to access, etc., etc. And I think that is a key phrase that we haven't sort of quite got to grips with. Yeah, we're still more or less passing people from pillar to post, from organisation to organisation, and I think that is something that I wonder if that is a good phrase to use all over the place. Yeah, in terms of no wrong front door, and then if you are incorrectly referred, that service puts you right rather than says, well, I'm sorry, no go from here on. Yeah, so that was all. That was just my comment.
Lovely, thank you. Have we got any other comments or questions from people? Okay, I would like to add my very grateful thanks to all of the people who've contributed to this. It's a massive piece of work, and as I said about our register of interest, it's a living document. This will evolve and grow and change over time. I think it would be really useful, as we've discussed, to have a development session looking at some of this, perhaps in the spring, to see where we're going, and particularly tying in with the city vision work and where it leads into the health and wellbeing agenda. So thank you all the people who've contributed to this. It's a great piece of work, but let's keep it moving. So I think we've been asked to consider, discuss and endorse, and I think we've done that. People happy? We can move on.
Yep.
Thank you very much. Right, finance, Michelle.
Okay, thank you, Chair. I've got sort of 3 papers, and if I just do a quick introduction to each one and then just ask for questions, if that's
that would be lovely. Thank you very much.
The approach that people are happy with. Okay, so I start with finance report up to month 6. Currently shows an overspend position, but we're pending a top-up allocation for our month 6 expenditure, which is related to COVID-19 additional expenditure, primarily linked to the hospital discharge programme. So, as you know, we have received top-up allocations between months 1 to 5. Month 6 top-up has been delayed slightly, hence why it doesn't say a break-even position. Continuing healthcare expenditure is reduced but that is linked to the hospital discharge programme that is currently still in place. Prescribing run rate has reduced as we further understand the price changes to category M in particular. And then the mental health extra contractual referrals. I think last time I talked about the work that we were doing across the council as well as health around the expenditure there and understanding the client base. So we're seeing a slightly improved run rate in that area. However, it's still significantly overspent compared to where we would like it to be. And I suppose just to remind the board that as a response to COVID-19 that we are in a completely different financial regime. And up until month 6, we had this, we had the suspension of normal contracting approaches with block income being spent, being given to NHS organisations in particular, and that we've got this top-up arrangement that's happening not only to CCGs but also to NHS provider organisations around us. And if you looked at anybody's reports up until month 6, you'll probably see a break-even position, or it will be a deficit position pending some top-up arrangement. I've got a little paper on the financial regime for months 7 to 12, so I'm going to stop there in terms of the month 6 board report and see if there are any specific questions that anyone wanted to ask.
Graham.
Yeah, Michelle, just on the detailed one on running costs.
Yes.
CSU charges 600,000. I just wondered what they were.
So the CSU provides a number of services to the CCG, and they have done for a number of years. That will include contract team, information technology, GP IT in particular, and we've got one other big one that is just slipped my memory.
Information governance?
Yeah, information governance they provide to us. Business intelligence. There you go. Eventually it gets there. The brain work.
Data.
Yeah. Alongside some smaller services that they provide to us, as Elizabeth says, information governance. So yeah. So it's a charge that's been there for a number of years.
Thank you.
Any other questions on this paper? Thank you. I think we have noted that. Michelle?
Brilliant. Thank you very much. Again, really short introduction for the performance report. CCG and providers continue to report a majority of performance indicators, and this report just summarise where there are exceptions and any mitigating actions that are being put in place. So there is some sort of not normal approach, but these indicators are being looked at and trying to improve them as we go through the year. We also have to note that every organisation is having to live with COVID-19 and therefore adapt their services accordingly, and that does affect the level of efficiency that is achievable. So the covering sheet highlights 111 call answering. It notes that the A&E demand and the action that's in place that should impact that and improve that, as well as elective performance indicators deteriorating, which again I think we reported last month with RTT diagnostics and the patients waiting more than 52 weeks increasing. As part of the restore and recovery process, we're expecting or trying to improve those indicators and trying to get as many services back on track as we can. But, that's ranging, isn't it, from primary care right through to acute care services as well. But that's going to continue to prove difficult given the increasing number of COVID positive patients, as we just heard from Helen as well. Again, I was going to stop at that point and see if there are any questions.
Graham? Or was that last time?
Sorry, that's an old hand.
Jackie?
Oh, well done,
okay. I was trying to understand a little bit. You might be able to help, Michelle, around how 111 First is partially is part of the deterioration of SCAS's performance in terms of calls answered.
Mm-hmm.
Do we know what
I can answer that one if that's.
Thank you, Elizabeth. I was going to send you.
So 111 First is a redirection for people to the emergency department. So it's trying to get people to the best place rather than them just going to the emergency department. Therefore, there are now a tranche of people who are contacting 111 in the first instance, rather than just pitching up at the emergency department. Consequently, the call volume has increased. These calls need to go through their call handlers and then be redirected appropriately depending on what's going on. So the volume has increased.
So it's actually for the right reasons. We just need to
It is because these people then get the help and advice they need as opposed to just turning up to the emergency department.
Exactly. Okay, so we can try and match that demand. That's exactly what needs to happen.
And this is we are a front runner, or whatever the term is, for 111 First. So this is a national programme that will be extended. So it is a case of 111 has to be looking to increase its capacity to manage this as it is rolled out across the country.
And then a couple more. One was the handover delays at PHU. Given that, I can see everyone's faces. Just bear with me.
No.
Yeah,
depressing.
We haven't got the same numbers of Type 1 attendances coming through. We're not even close to the amount that might be coming through, and there's delays in handovers. You know, is that COVID impact? What's happening?
Are you able to answer that one as well, Elizabeth?
I don't have a straightforward answer.
No, I don't.
We are still struggling with the fact we have one of the best see and treat levels for ambulance services. So their non-conveyance rate is the highest in the whole country for ambulance trusts. We have an extremely effective clinical assessment service, triaging calls from 111 for the lower levels of acuity ambulances, so what are known as Cat 3-4 ambulances, and we have a really good conversion rate of those to non-conveyance and using other services. And despite that, we've got handover delays. So I don't know the answer, but a lot of work is going on around it, and we will get a more detailed answer from those who do know more detail than I.
Right.
Innes, have you got something you can add?
I was just going to add, there is an element of COVID impact.
Yeah.
Yes, as we know, and we know from Helen's presentation earlier, obviously, there's an increase in people needing to go to hospital with COVID-related. And this time, the difference between this wave and the first wave is that the hospital is, importantly, trying to maintain its non-COVID business as much as possible, because clearly people need their hospital treatment as much, whereas in the first wave, we, I think the phrase nationally uses emptied the hospitals. We made sure there was loads of bed capacity in that hospital for the first wave. So they're trying to balance, probably on an hour-by-hour basis, their COVID activity with their non-COVID activity. Obviously, with more people in the hospital, cohorting people safely, so that the risk of any cross infection with COVID becomes more of a challenge. You know, aspects of physical space and workforce and et cetera, become more tricky to manage, and we suspect that might be contributing to a slowing of some of the processing, and that might therefore contribute to some of the delays.
Thank you, Innes. That's very helpful. I was going to ask very briefly about patient-initiated follow-ups. I don't really know what that means.
I wonder whether Simon could help out, because he's been very involved in the elective care programme.
Hello, everyone. Hi, Jackie. As I understand it, patient-initiated follow-ups is essentially for outpatient, so involvement with secondary care. Most of patient encounters, often the first assessment is usually about assessment and management of treatment, so initiating from diagnosis and starting treatment. Many times patients have good outcomes from treatment, and actually a problem is resolving or resolved. And then there's, well, classically, we would see them again in clinic, say, oh, good, things have improved, and then discharge them. But then there's that question as to that second appointment or that last one where you're saying things have improved. Is that really adding anything to the patient's journey? And the aim for a patient-initiated follow-up would be actually to make contact again for that appointment, where actually there will be more value to add from discussing around treatment, or if the treatment's not working, but for patients who feel that actually their problem is solved, they don't need to go back to the hospital, and actually we might be able to use those appointments to deal with additional patient demand.
Okay, so you wouldn't necessarily physically see somebody, or you would only go back if you felt there was a reason to go back. Is that roughly it?
Yes.
Patients have that understanding that if there is a problem, you can initiate a follow-up, otherwise go about your life.
Yes, and there's often, so the aim would be that it's not a fixed time, but rather there's a window after that appointment where they could initiate that follow-up if it was needed at a particular time. So it's not a saying, well, in 4 weeks you don't answer. No, I think the window, I think it varies, but so I'm not certain, but I think it was 6 months, depending on certain specialties and problems. But that will depend on departments and what service.
Thank you, that's really helpful.
And I know that places like rheumatology and gastro are doing it for patients who would have otherwise been on long-term follow-up, now can choose when they get seen. So they're not a fixed window, but potentially it may be a year after their last contact, but they have a flare up of their chronic condition and they can contact and make that appointment.
It was actually first pioneered, as far as I'm aware, in breast cancer. There was a trial where the low-level breast cancers weren't actually followed up. They left it to patients to contact either their GP or the clinic, and that was considered a bit controversial, but it seemed to have worked. People are quite well informed and conscious of needing something. Yeah, so it can be done, but it needs to be well organized.
Thank you.
Okay. So any other questions or comments about the performance report?
Brilliant. Shall I
then?
So yeah, so we thought, given where again we talked about last time round, we just received the national guidance on the financial regime for the remainder of the financial year. The CCG has been fully involved in the Hampshire and Isle of Wight system, aligning assumptions and producing a financial activity, performance and workforce plan, utilising that guidance. And the paper that you see before you is just highlighting Portsmouth CCG's element, financial element of that. So you can see a summary of our allocation that we had for months 1 to 6 and our expenditure against that, assuming we get the top up, and then months 7 to 12 at a very high level. So the changes to the allocation, you can see the difference between months 1 and 6 and 7 to 12, and that we've got a revised allocation of 173 million pounds for the final 6 months, and a current expenditure plan of about 169 million pounds. So therefore, as part of the Hampshire and Isle of Wight system plan, we're showing a surplus against our allocation of about 3 million. And we're going to have continued discussions about that as a whole system, because other organisations are currently showing deficit plans, which is slightly at odds to have a CCG in a surplus position compared to others being in deficit positions. So as we sit here today, that is our current plan. I'm saying it might change. It might change towards us maybe looking more like we're a break-even organisation, but I will keep you updated if that happens and how and why it happens if we go along that process. So our month 7 position, which we have just closed in the last couple of weeks, we're showing a surplus position which would be in line with us achieving a £3 million surplus for the forecasted year-end position. So some of the changes that have happened from the month 6 information to month 7 to 12. So the Hampshire and Isle of Wight system will now receive the top-ups and the COVID-19 allocation into Hampshire and Isle of Wight, and those allocations, if you like, have been shared out between all organisations across Hampshire and Isle of Wight, with the expectation that we don't require any further top-up or any further COVID-19 monies as part of our plans. And our CCG allocations were changed and adjusted for revised block payments to each of the NHS organisations and a small element for growth, so that we could address such things as winter plans, etc., within our plans. It excludes the hospital discharge programme, which is again slightly changed in the final 6 months compared to the first 6 months, but we're working really closely with our City Council colleagues on that to make sure that we're only asking for the monies that we require. And as I said to you the last time round, our teams are working really well on that process, and we've got much more open and transparent ways of working as a result of this crisis, if you like, which is great, isn't it? Because that's what we need going forward as well. There are some technical discussions that are still going on from a Hampshire and Isle of Wight perspective, but in the meantime, the message has been get on with the plan and do what you can within the allocations that you've been given, noting that we've got the second wave that we need to deal with as well. So as I said earlier, what the system's trying to do is restore and improve services where we can, whilst trying to manage and work within the COVID-19 pandemic situation. Again, it's brought here to make sure that we're all aware that those are the changes that we've made. We've tried to incorporate as many of the plans as we know them today. There are some things that still sit outside that, but by and large, most things are expected to be dealt with within the allocations that we've been set. I'll stop talking.
Thank you very much for that. Questions and comments on that paper? Obviously a detailed explanation, Michelle. Oh, is Andy going to come in? No.
Andy?
He's sort of flickering on his mute.
No, sorry.
Yeah, and as I say, if as and when there are any changes, then I will make the board aware.
Thank you. So we're being asked to note this paper. People happy with that?
Yeah, agreed.
Right.
Thank you.
Policy and safeguarding report, Karen.
Hi, Elizabeth. Yeah, thank you. The report we've got in our paper is from the October Quality and Safeguarding Committee, so it was discussed then. A couple of things I just wanted to pull out for people, although the details in the paper. We're aware of the 111 First programme that's been running. What we're hearing is there's still a number of people walking into A&E at PHU, and many of these people have got mental health needs. And what's been identified is that there isn't actually there's a gap in respect of the mental health diversion from emergency departments, and that's possibly because SCAS 111 wasn't included in the process or the pathway. So there's now some work being undertaken to develop a SOP for the services so that we can address the specific needs of people with mental health, and our commissioners are working closely with them around that. The pulmonary rehabilitation service offered by Solent NHS Trust, that's seeing an increase in demand. I think some of that was before COVID, but that's continued to rise, and I think that's is definitely on the increase, specifically because of the longer term effects of COVID symptoms. We're reviewing the commissioning arrangements for that, but what we're conscious of is that people don't want video consultations, they want face to face, so it's going to take some work to look at how we address that service and make sure that it's fit for purpose. Care UK, who run our urgent treatment centre, I don't know if people know, but they've changed their name to Practice Plus Group, and we're continuing to monitor the quality of that service because we've obviously got concerns about the impact of their staffing, but they've more recently become part of the Portsmouth South East Hants escalation framework, and a local SOP is now in place, so that feels as if they're sort of engaged better with partners, so that's working better. In terms of our residential and nursing care homes, the paper talks about having 4 outbreaks. I think now today we've got 3 COVID outbreaks in our homes, so there's been a slight reduction. We also talked about what our protocol was around visiting, because I know we're locked down at the moment, but there's been a lot of media interest around visitors into homes across the country. But what we've been assured is that the CCG have supported our local homes in developing guidance that supports people going into the homes, obviously observing the social distancing and PPE, but actually we've looked at the national guidance and tried to develop local guidance that works for people, so hopefully that's good. The other thing that there's been some work on more recently is around the SDP have developed a hospital discharges form, because what you'll pick up throughout the report is that the number of discharges from PHU have possibly been inappropriate. People weren't fit for discharge and they were having to be returned. So more recently there's been a form that looks at COVID and making sure that people are on the right pathway when they get discharged, and discharged to the right designated setting. Finally, the bit I wanted to pull out is around safeguarding, our own capacity within the CCG to deliver safeguarding. We have vacancy within the team, and this has quite an impact on our ability to meet our statutory requirements for safeguarding. We have gone out to advert, we have shortlisted and have got 8 applicants, so we're quite optimistic. But because of our concerns that we might not be able to meet our statutory requirements around safeguarding, we have added it to the risk register for our quality and safeguarding team. We also had a further discussion today because of the second wave of COVID. This is now having an impact on the team's ability to cover all of what's expected of them. They've got quite competing demands, because as like last time they were asked to offer training, fit testing, and that continues. That started to continue again. So we talked about setting the priorities for the quality and safeguarding team for the next few months. But the governing board need to be aware that possibly we won't be able to report in quite the same way for the next few months, because their priorities will be more about making sure they can respond to safeguarding incidents, making sure they'll be able to provide support into the community, residential and nursing homes. I think that was all I was going to say. I don't know if there's any questions.
Well, I'm delighted to hear we've got 8 applicants for the safeguarding role, because I had understood that it isn't just a local issue, but it's a national issue, that there is a shortage of suitably trained people. So the fact we've got 8 people suitable is fantastic. So
yeah, you're absolutely right. Around the system, there's a shortage of safeguarding. We actually had more applicants. I think we shortlisted to 8. So that really is positive. Yeah.
Fingers crossed we find one applicant that will do.
Yeah. Yeah.
So, Jackie.
Thank you, Karen. You actually answered most of my questions. I was really grateful. There was a couple that I just wanted a bit more clarification on, only a couple. One was on stroke direct admissions, where we didn't seem to meet the 4-hour target, which seemed like quite an important target.
Jackie, I haven't got any further information about that, so I would have to go back for you.
Would that be all right, just to get a bit of on that? And the other one that probably perhaps alarmed me a bit more was the unaccompanied asylum seeking, the minors who are not going to not been having their TB tests done, and that it says the service will no longer accept referrals for this group of people.
We did actually discuss that, and I think there was a...
I can come in on that.
Oh, please.
Yeah, sorry, it's Elizabeth. So as another job, I am designated doctor for the CCG for looked after children. So I've been very involved in these discussions. So TB testing has only been available to be done through the chest clinic up at PHU. And there has been marked difficulty in appointing the young people to these clinics. And there was major concerns that with rise in COVID again through the winter, that the clinic would not be able to accept referrals. So that's the background to it. The hospital said they were withdrawing the service, but that has had a contract discussion that actually we still need the service. It has gone away marginally because now we do not receive unaccompanied asylum seekers, asylum seeking minors into the city. So we're not getting an ongoing need for those to be tested at the moment. However, the whole thing is being looked at as part of the Looked After Children review that is being undertaken by Children's Commissioning. And we are looking at how that service would be delivered differently. So it's a bigger piece of work. And I understand that the backlog had been, the young people who had missed appointments from a particularly bad week some months ago has been addressed.
Oh, good. That gives a real level of reassurance. Thank you. You said we're not going to receive any minors into the city.
Currently, at the moment, because the city children's social care was at a saturation point. Alison is probably better to speak to this. It's her department. I'll stop wittering. Alison.
That's all right. Yeah, it's important to get this right. So we have had discussions with the Home Office about the pressures on the city in terms of our ability to provide safe care to unaccompanied asylum seekers, as well as to all our looked after children. We were getting increasingly concerned in the early autumn that because even with the really strong fostering service that we have, and we have a really good in-house fostering service, we didn't have enough placements for everybody, and we had nearly 40 unaccompanied asylum seekers placed in London, which was much more difficult for us to provide really good care for them, with social workers having to travel to and fro, and the partnership network not being able to wrap around these young people. So we actually said to the Home Office, look, we don't think this is safe. We don't think we can provide safe care. There is a system called the National Transfer Scheme, where you can refer young people in who have arrived with your authority and have them transferred to the care of other authorities. And we had a number of referrals in, but they weren't being progressed. So essentially we said to the Home Office, you need to progress these referrals, and you need to provide, you need to persuade other local authorities to step up for the time being, to take new arrivals in Portsmouth, because otherwise we cannot provide really good safe care for those young people. And it's the needs of the young people which have absolutely driven this. So at the moment, that's the position, and we're not discharging our legal duty on this. And there is, for those who want to see this, a formal monitoring report that went to the last full council meeting about this. But we're in weekly contact with the Home Office. About 11 young people have been provided alternative placements in other local authorities since we took that decision, which was the beginning of October, and we're keeping it under close review and close working with the Home Office and with those other authorities. So the young people are getting the support. I would argue they're getting a better deal, if given that a number of different authorities are part of the solution now, than they would have been if we'd carried on taking everybody who's referred to us. But we will at some point get back to doing that. What we've argued publicly is that the government needs to make that national transfer scheme a mandatory scheme, so that it works effectively, efficiently, without having to have all these negotiations and persuasions going on between the government and individual authorities. That we're awaiting a decision on that. I hope that's helpful. I don't want to take up the board's time too much, but it is quite a sensitive and important issue to get right.
Absolutely, and thank you, Alison. That's very clear. And as I say, we are working on the assumption we will be getting unaccompanied asylum seeking minors back, and very much working on a health pathway that will better support these young people when they arrive. So it's not gone away. The TB bit is a small part of a much bigger piece of work that we're doing, and definitely progressing.
Thank you. That's really helpful, and as ever, putting the young person first, and where we need to share responsibility for best care. Then
Yes.
Absolutely. Thank you.
Anyone got anything else? Any other questions? Thank you very much. So we're asked to note this report, and we would very much like the feedback about the safeguarding role appointments. So need that, as that is a big concern. So item 12, we're now on to page 132. So moving through this large pack of papers. This is a good job it's not real paper, isn't it? So this is a review of our standing orders. It leads on from the feedback about our change, the refresh on the Constitution, and we have updated the standing orders, and they are very clearly listed on the front sheet. So I'm not going to read them all out, unless anyone wants me to. But I would just ask whether anyone's got any particular questions about any of these. Any comments, Graham?
Just to check in, really, at 4.1.3 we say meetings of the governing board shall be held at least twice per annum. Yes. I'm assuming that's just a kind of minimum statement and not a sort of statement of intent that we might have less governing board meetings than we do currently.
I would agree that, as far as I'm aware, that is the minimum. Justina, help me out.
Yes, it is.
I'm not aware of any change to our current plan.
No, that's the minimum amount.
Okay, thank you.
Nick?
Yeah, just wanted to ask, 3.1.16, which is the member, excuse me, flogging my throat, the member practices and each member practice has an equal single vote. Obviously, things have changed quite a bit since CCG first came into being in terms of the quite large and different sizes of the practices. Is this still in keeping with what we should be doing, and sort of with other CCGs in terms of that? Because obviously in things like in the Primary Care Alliance, it's kind of the voting is weighted for list size, isn't it? But just wanted to ask the question, really.
Okay, I think if anything, haven't practices levelled out a bit more of late with the latest mergers? I don't know. I know we do have one very large practice. I've not been party to any conversation about that. What are people's views? No particular feelings. Justina, have you heard anything?
Yeah, I can certainly have another look at that, Nick, and we can perhaps have a discussion offline around that.
Yeah, just to make sure that it was fair and also in keeping with what other organisations do, I guess.
Yeah.
Yes, indeed. That sounds a plan. Then we've got Margaret and Dave.
Mine is quite a quick one. The 3.1.4, the accountable officer. Is that the accountable officer to the ICS?
Yes.
Yes.
Because of our previous paper that we've agreed to, the accountable officer will be the same accountable officer of the Hampshire and Isle of Wight CCG and the ICS.
Yes. So this is all about in future then, because we have an accountable officer in place?
Linda is currently our accountable officer.
So in a different title, isn't it? Chief Clinical Officer is the title rather than accountable, but yes.
Yeah.
Yeah, so Elizabeth, can I just come back on that?
I'm now confused, sorry.
These arrangements within the standing orders are for our governing board as it currently stands, taking into account the recommendations that were approved previously in the October extraordinary meeting. One of the things you will also see that hasn't been included as of yet, because that's a decision you made today, is around the composition of the governing board, which you did earlier on in this meeting. So there will be some slight changes to this based on those recommendations. But this was following your the actions that you took and the recommendations you agreed in October.
Yeah. Right.
So this is our accountable officer. The legal name, the legal name for Linda's title is really an accountable officer.
Right. So that section will change given our decision today.
Yes.
Yes. Okay. Thank you. Just clarification.
Sorry, I'm jumping ahead to changes we will be making. Right, David, and then Dave.
Yeah, it's just a point of clarification, really. In 3.1.6, in the summary on the cover paper, it refers to the clinical leader. This is now separated from the role of AO/chair. When I look at 3.16, I'm not sure I see a reference to the chair, and I just wonder whether somebody could explain to me what the meaning of that is.
Yes, apologies, David. I should have made that clearer. So in the original arrangements around our constitution, the clinical leader was stated as being either our accountable officer or our chair, which is why both of them are included in there, because that has changed.
Yeah, okay, thank you.
Dave?
I just wanted to add my support to Nick's comment about 3.1.16, and I'm not sure it's quite as straightforward as perhaps we would think, particularly in the PPCA, because of the risk of influence being heavily weighted. So I'm just wondering whether, if any change is going to be proposed to that section, there needs to be a wider consultation with member practices.
Thank you. I think we'll do a bit of digging in that and take that for wider consultation. You happy with that, Justina?
Absolutely. Thanks, Chair.
Right. So any other comments? So we've been asked to review and consider, which we've done. We are happy to approve the above on the changes. So, but we've got the question which is not mentioned, and because it hasn't changed, about the practice vote. Does that make sense?
Do we need to approve it subject to a clarification on that point, Elizabeth?
That's the phrase I'm looking for. Yeah. Alison.
Just very quickly, I just wanted to check. It says that the City Council representation is through the Chief Executive. So would that mean that in future I wouldn't be a member of the governing body? Just for clarity, it's not a problem, but just checking.
As I mentioned, so one of the recommendations that you didn't do in October was around the composition of the governing board, which has been done today. So that will now be included within this document.
Oh, I'm so sorry. Yeah, okay.
Fine. So we need to move forwards and look at that.
Okay.
Okay. And yes, so that's part of our next steps that we need to be addressing. David.
Sorry, Liz, just to be clear then, so the Director of Children's Services would continue as a board member. Is that the intention?
It is at the moment, and part of the next steps will be to review the board composition.
Right, thank you.
Okay, so I'm never very good at phrasing this. Are we happy to approve the changes as listed on the front sheet and accept the rest of the document pending clarification of the practice member vote?
Agreed.
Is that right?
Yes.
Yes.
I know what you mean.
Right. Okay. So thank you very much for that. And then moving on, we've got the committee annual reports. So these two annual reports that we've got from the Audit Committee and REMCOM are here because this is a statutory requirement for us to receive them. In case anyone wonders, the Primary Care Commissioning Committee does do an annual report, but that has to go to NHS England in the first instance and is currently work in progress. We will get sight of it once it's been completed and gone to NHSE, but these are the two annual reports. So we have Andy as Chair of Audit Committee and Graham as Chair of REMCOM. Do you want to make any comments, raise any points on these? Should we start with Andy?
Thank you, Elizabeth. The report is as you see it, really, and it just indicates the work we've done throughout the year, our attendance, outcomes, and what we intend to do in the future. I'm sure everybody's had a chance to read through it, but it's been a very good year for the Audit Committee. A lot of work taking place, and the attention to detail, I think, this year has been better than in the past, and we're looking to improve on that. So I commend this to the board.
Lovely. Thank you very much. Graham?
Yep, similarly, a summary. We have 2 meetings a year generally, and as you can see in the paper, cover areas generally around payroll, staff engagement, pay and policies, and reviewing workforce trends amongst the CCG. And similarly, I commend this to the board.
Lovely, thank you. The board happy to receive these? Happy with those?
Yes.
Note them. Lovely, thank you. Minutes of other meetings. Does any of the chairs of the meetings, so we've got Primary Care Commissioning Committee, Audit and Health and Wellbeing. Are there any other comments to be made on these papers?
Not from Health and Wellbeing.
No.
Just one from Primary Care Commission, and that is we had a meeting in October, which doesn't appear, the minutes don't appear to have been there.
Because they weren't been approved yet. We only get approved minutes.
Okay, that answers my question, because it feels like quite a long time ago, July. But yeah.
No. Any other comments? One thing I would like to mention, and just generally looking at our attendances at these different committees, is really very high. A couple of us were reminiscing to days gone by where some committees would meet and there would be hardly anyone there. we have really good attendance, so everyone keep up the good work. It's good to see so many people turning up and taking part. It makes it feel like we really own this stuff. So thank you very much. This brings us to the end of our meeting. The next meeting in public will be on Wednesday the 20th of January at 2 o'clock and will be streamed online via Microsoft Teams. And I would like to say to Peter, please can we end the live streaming? And Justina, you can end the recording.
Will do, Chair.